So our next session will discuss the progress that we have made so far toward achieving universal health coverage and other health security goals. And it will also tackle the challenge of measuring and monitoring progress toward our goals in the health sector. So I'd like to ask the panelists to come up to the stage, please. All right. So at this point, I would like to turn things over to our moderator for this panel, Jeanette Vega, the director of the National Chilean Public Health Insurance Agency and a steering committee member of UHC 2030.
Thank you. So good morning, everyone, and welcome. My name is Jeanette Vega, and I have the honor to moderate this session. Let me begin by describing the structure of the plenary. First, we will hear a joint presentation between WHO and the World Bank, presenting the Global Monitoring Report findings and the 10 pilot country reports produced by the Tokyo Joint Initiative. Then, we will hear comments from a wonderful group of panel speakers, and after that, we will open the floor for questions from the audience to the panel. Finally, if time permits, I will summarize some key messages. So let's begin then. I have the honor to introduce Agnes Sukat, John Grove, and Adam Wagstaff. Dr. Sukat is the director of the Department of Health System Governance and Financing in the cluster on Universal Health Coverage and Health System at the World Health Organization. Before joining WHO, she was the global leader for health, nutrition, and population for the World Bank Group, and part of the Lancet Commission on Investing in Health, where she was involved in creating Global Health 2025. Dr. Sukat previously held the position of Director for Human Development for the African Development Bank. She has many publications to her name. She's a French national and holds an MD and a master degree in nutrition from the University of Nantes, and a master in public health and PhD in health economics from Johns Hopkins University. John is currently the Director of Information, Evidence, and Research at the World Health Organization. Previously, he worked as the Deputy Director for Evidence and Policy in the NCH team at the Bill and Melinda Gates Foundation, where he led the team's strategic information and evidence activities. He holds a PhD in Health Services Evaluation from the Royal Melbourne Institute of Technology, a master's in applied anthropology from the University of San Francisco, and a bachelor in international relations from Kent State University. And then I have my dearest friend, Dr. Adam Wagstaff, who is very well known to all of you. And Dr. Wagstaff has been for several years with the World Bank. He's a worldwide, very well-known researcher, and he has been working on several issues like health equity, efficiencies of investing in some health issues, and so on. So I'm very glad to have such a distinguished panel, and let me give the floor to Agnes.
Thank you very much, Jeanette, and good morning to everybody. Let me express my gratitude to the government of Japan for their gracious hospitality and the joy that I have to be in Japan this morning. So it's my honor and my privilege to present the Global Monitoring Report of 2017 on universal health coverage. And this report is the product of broad collaboration between the different WHO regional offices and WHO headquarters in Geneva, together with the World Bank, as well as the OECD and UNICEF who joined the team. So we are here today, a choir of three, but we represent a much larger team of more than 30 people and different experts and specialist demographers, epidemiologists, economists who worked on this report for the past 2 years. And if I start where we started is actually the framework for universal health coverage. So I don't know if we have slides. I have to go there. Oops. So how do we measure universal coverage? And very often there is a question as to how universal health coverage is actually linked to health impact and outcome as well as to health system. So here we've been using a quite simple framework with 3 levels of indicators. Health system strengthening is what we do, that's the actions, that's what we invest in. And it's complemented by actions in different other sectors in the determinants of health. And those together produce coverage. Universal health coverage is defined as all people and communities receive the quality health services they need without financial hardship. So here we're talking about people having access to health services and using those services in both the quantity and the quality that they need. And it is by achieving universal health coverage that we contribute to the impact on the Sustainable Development Goals. Sustainable Development Goals 3, of course, equitable health outcomes and well-being, that's the central outcome of universal health coverage, but not only. We know also that universal health coverage contributes to other SDGs, not only SDG 3, SDG 1, poverty and reduction of impoverishment, quality education, particularly when it comes to early childhood development and nutrition, gender equality, particularly with all the interventions that address women's health, inclusive society, because universal health coverage is a social contract and it's always about solidarity and cross-subsidy from rich to poor and from healthy to sick. But it's also more than that. And last year, WHO, the OECD, and the ILO produced a report on that for the Commission on Health, Employment and Economic Growth that actually shows that investing in the health sector and investing in universal health coverage can also be a driver of both employment and economic output and contribute to inclusive economic growth. So how do we translate that framework into measurement? We know that UHC is often defined as the cube, as 3 dimensions, but we can sort of unbundle these dimensions in first 2 fundamental dimensions, that is service coverage. Everybody, irrespective of their circumstances, get the health services they need, and financial protection. Nobody suffers financial hardship as a result of getting needed health services. But these 2 dimensions can express themselves also in a 3rd dimension of equity, which is that it's both equity of service delivery and equity in financial protection. And I'll hand over for the first dimension, the dimension of service coverage, to my colleague from WHO, John Grove. Thank you very much.
Good morning, everyone. It's a pleasure to be here with all of you. I will be talking about the global monitoring of service coverage as a component of the report. And I think it's important to mention that while we're moving from the MDG into the SDG era, I don't know if you've noticed, but a lot of the indicators are a bit more complicated. And if we look at 3.8 and specifically 3.8.1 for service coverage, there's no one magic way of doing it. It actually involves various components from RMNCH to NCDs to infectious disease to systems capacity and components, and requires us to pull together a number of indicators and information to make an assessment on our progress for coverage. And so what we've developed is an index that includes 16 tracer indicators. This is the result of work that's been going on since 2012. It's a peer-reviewed index that will be actually released this week. And it actually provides us a tool to use to scan the horizon for UHC. And it's important to keep in mind that indeed it is an index. And so much like a stock market index, it pulls together a number of different numbers to assign a value. And then the value really serves as an invitation to go a little bit deeper into the data and information. It's relatively easy to calculate, but it certainly isn't the final word on essential services. And I want to say the word tracers again. It should not be thought of as these are the only interventions for UHC that are embedded in the tracers, but rather these are the items where we have data comparable in most places across the world where we can make some kind of assessment. So starting with the point of departure is to look at the tracers from the various categories that are outlined in the report and to look at data availability. And we actually find some interesting things. That actually for most of the data that we need, about 72% of the data is available. And because of the intense focus on standardized household surveys over the last era, we actually find that we have more comparable data and information through those surveys in some of the developing countries. And some of the more challenging data actually is from developed countries, where we have less standardization across. So that was something that was illuminating as we move forward. And on the right, you'll see that overall, we have varied levels of service coverage values. So if you look at the index, and again, it's all outlined in the report, the average is around 64. But we have a range of 22 to 86 on the spectrum as at data at 2015, where we have the highest values for East Asia and North America and Europe, and Sub-Saharan Africa at 42 and South Asia at 53. So again, this is a value that comes from a number of indicators that leads you into the index, which will show you which pieces are driving those trends. We've looked across the information, and we don't actually have enough information for trend setting too far back in the past across all 16 items in the index. But we do have time trends for 9 of the tracers. And where we do have those time trends, we actually found from the year 2000 to 2015, we've seen quite a bit of progress on these particular tracers. While at the same time, the converse of progress is always gaps. And as we look at these tracers and the converse, we find that we still have 1 billion people living with uncontrolled hypertension, more than 200 million women inadequately covered for family planning, and we have 20 million infants still not receiving DPT over that time frame. So while there is much to celebrate across these particular tracers, there are also gaps that continue. And our team has been working hard with the bank and other colleagues, and you've heard the number, or at least the quotient referred to this morning as essentially half the world's population not receiving the essential services that they need. Another key important piece that Agnes referred to was the role of equity and the need to go even deeper into the data and look at our trends in terms of equity in society. So we looked at 7 basic MCH services where we had trend data, where we were able to go back even further in time. And we actually saw a decline in equity since the 1990s. And we looked specifically at mother-child pairs. And we saw that of those interventions, we had the steepest declines in coverage among the poorest. And the wealthy remained flat, somewhat consistent. And essentially, only 17% of mothers and children pairs in the poorest fifth of households in lower middle income countries received at least 6 of the 7 basic maternal child interventions that we looked at, whereas 74% of the wealthiest quintile still received many. So there continues to be more work to be done on the equity front. We need to continue to design our programs and our monitoring to ensure that we can monitor equity over time. It's important to keep in mind that, as I said earlier, the index has helped to reveal a number of things. The first being that we are really coming into the next era of measurement. It's helped us to create a kind of wedge or an analytical framework that we can use to continue to look at various elements of UHC over time. And so we are engaging in further technical development on the index. We will continue to update the data, particularly for things where we've used proxy information, where we have not had good treatment information, such as on NCDs. We're looking towards continuing our work as a reference group on this, together with other agencies, but not just the analytics and tools, but also looking at how to support institutions and people and systems, what tools are needed, and what are the foundational aspects of health information systems that need to be strengthened so that we can inform our care and practice into the future. So with that, I thank you very much for your time. Please read the report. I know we're in a world of Twitter, but most of your questions will be answered in the text. So thank you.
So good morning, ladies and gentlemen. So as Agnès mentioned a few moments ago, there are in effect 2 sides to the UHC coin. The first side, which John just spoke about, is making sure that everybody, irrespective of their circumstances, gets the health services they need. The second side of the coin is making sure that when people do get needed services, they don't suffer financial disadvantage, and that's what I'm going to talk about in the next few moments. There are 2 indicators we use to look at this side of the coin. One is catastrophic payments, and the other is impoverishing payments. Catastrophic payments are payments that exceed a particular threshold of total spending, and the thresholds in the SDGs are 10% and 25%. This is SDG 3.8.2 for those of you who like numbers. Think of catastrophic spending as spending that forces a household to make a sharp reduction in its living standards. So loosely speaking, exceeding the 10% threshold means seeing your living standards go down by more than 10%. For some people, in absolute terms, that may not be such a big deal. So this second indicator, the impoverishing spending indicator, gets at the question of whether the reduction in spending, non-medical spending that's brought about by out-of-pocket payments, is a big deal in absolute terms. In particular, does it push a household below the poverty line? In the SDGs, the extreme poverty line is set at $1.90 a day. So one of the indicators we track is whether out-of-pocket spending pushes a household below $1.90 a day. To do this work, we need household survey data. We need survey data that gives us data on what households spend, not just those who use services, but we need a picture of everybody, and what they spend on things other than healthcare. We identified over 1,500 household surveys that were potentially useful here. There are many more actually that exist but aren't catalogued in the world's microdata catalogues, and many of these data sets are not accessible. So one thing I'd really love for all you to do, if you're passionate about UHC, which you all are because you're here, get passionate about giving access to researchers to analyze household expenditure surveys. The rich countries very often do not do this. The United States, the United Kingdom, Ireland are countries that do it. Anybody can apply to access and use these household survey data. There are plenty of rich countries that don't do this. Several developing countries actually do this. South Africa is a shining example of making data accessible. So please go home, see if your country makes household survey data accessible, and if not, pressure your authorities to do something about it. Sometimes key variables are not collected, and sometimes the surveys, unfortunately, aren't very good quality. So we ended up with just over 500 surveys we analyzed. These are over 10 million households that were interviewed across the world, covering 133 countries, and 93 of these had more than one survey, a survey at different points in time. The dark green countries here are countries that have surveys both in the most recent decade and in the earlier decade. So this allows us to get not just a snapshot, but also a sense of how things are evolving over time. These are the results for catastrophic spending. The number to keep in mind is 800 million. 800 million people spent more than 10% of their total expenditure on health in 2010. These are the left three bars in this chart. You can see this figure's going up. 588 million in 2000, going up to 800 million in 2010. If we look at the figure for 25% of total expenditure, we inevitably get a smaller number, 179 million for 2010, but again, the figure's going up. The figures look different if we look at rates in terms of the geographic concentration. If you look at the left bars, perhaps inevitably, because a large number of the world's population live in Asia, that's where we see the majority of people incurring catastrophic expenditures. But look at the right chart, you see that in terms of the percentage of people incurring catastrophic expenditures, the biggest numbers are in fact in Latin America and the Caribbean, where the numbers went up between 2000 and 2005 and then came down between 2005 and 2010. The region, interestingly, that's seen a consistent decline over this period is in fact North America. The picture looks a little different if we look at impoverishment. So if we think about $1.90 a day, this is the extreme poverty line for the SDGs, 1.1.1. 100 million people were impoverished by out-of-pocket expenditure in 2010. That number has gone down. It was 130 million in 2000. If we look at the $3.10 a day poverty line, which is the poverty line that you can think of as relevant for lower middle income countries. Think of the 190 line as relevant for low income countries. If we look at the 310 poverty line, the number has actually gone up. So 122 million people were impoverished in 2010 at the $3.10 a day poverty line. Again, Asia dominates on the left-hand side of the chart, but this time Asia dominates too on the right-hand side. The right-hand side giving us the fraction of the population that's impoverished. The good news is that that number in Asia, the fraction, has come down consistently over time. It's also come down in Africa, but stagnated a little between 2005 and 2010. You see in Oceania and Europe, the numbers are basically zero. Some people say impoverishment is only an issue for developing countries, and that's true if you pick the extreme poverty line, and to some degree the 310 poverty line as well. So on the left-hand map here, what you see is the high-income countries are all shaded very, very light. In fact, they're the lightest of the 5 shades here. So at $1.90 a day, there are in fact no poor people, whether caused by out-of-pocket spending or any other factor, in high-income countries. But if we take a relative poverty line and set that at 50% of median household consumption, we see impoverishment in high-income countries, including in high-income countries that claim to have health systems that actually protect people from out-of-pocket expenditures. Thank you.
Thank you. Thank you to the panelists, was a very nice presentation, short and sharp. So let me now invite, let me thank you, the panelists, and invite our wonderful panel speakers. Many thanks. So please, the panelists. Thank you and welcome. Well, you see, we really worked very hard to have a gender balance in this panel. So let me introduce Ms. Yas Solia. She is the Deputy Minister, Planning, Research and Development, Ministry of Health and Social Welfare, Liberia. Ms. Yas Solia has been the Deputy Minister at the Ministry of Health since 2011. She has more than 15 years working experience in areas of monitoring, evaluation, research, policy, and strategic planning in the health sector, and has overseen the development of the 10-year policy and plan of the Ministry of Health and Social Welfare. Ms. Solia led the team of experts that developed the post-Ebola investment plan for building a resilient health systems in Liberia. Then we have Dr. Aisha Gaush Pasha, Minister of Finance, Punjab of Pakistan. Dr. Aisha has more than 27 years of experience in teaching and research work, which focused on macroeconomic issues, social policy development, governance, public finance, and urban and regional economics. She has a PhD from the University of Leeds in the United Kingdom and is currently serving as Minister for Finance, Government of the Punjab, undertaking the fiscal management of the government of the Punjab. Welcome. So then we have Ms. Rosemary Mburo. I hope I say it right, okay. From Waki Health for All in Africa, Kenya. She is the Executive Director for Waki Health, formerly known as World Health AIDS Campaign International. She has over 12 years of international experience in areas of public health research, programming, and advocacy. Rosemary is a civil society organizer who has extensively worked on building and strengthening civil society networks and platforms on health-related advocacy and campaigning in Africa. She holds a Master in Public Health from Ohio University, a Master's in Business Administration from Frostburg State University, Maryland, and a Bachelor of Education from Kenyatta University, Kenya. Then we have Dr. Gunal Rodier. Dr. Gunal Rodier is the Director of Country Health Preparedness and International Health Regulations at the World Health Organization. Until November 2015, he was the Director of the Division of Communicable Disease, Health Security and Environment at the Regional Office for Europe in Copenhagen. He has extensive experience in the international surveillance and control of emerging infections, epidemic-prone diseases, and global health security. Dr. Rodier's main degrees include an MD from Port Royal Medical School, René Descartes University of Paris, and a Master in Science in Clinical Tropical Medicine, London School of Hygiene and Tropical Medicine. And then we have, and I'm going to say, Dr. Pukesh Chawla. This is a private joke we had in the discussion. Dr. Chawla is the head of knowledge management in the Human Development Network at the World Bank. Prior to this appointment, he worked for over 20 years in the health sector, his last position being sector manager of health, nutrition, and population in the Human Development Network. Over the years, he has worked closely with governments and international development partners in Europe, Asia, and Africa on a variety of health sector issues. Prior to joining the bank, Dr. Chorla held a research faculty position at Harvard University in Boston. So let's begin with the questions then. I'd like to begin with Minister Solia, and I'd like to ask, what in your view are the implications of the global monitoring report finding and the country studies in terms of how countries can develop their capacity to monitor universal health coverage?
So thank you and good morning. We're happy to be here and thanks to the organizers for inviting us to this important forum. In order for us to be able to understand the capacities that we have and what we need to do in order to monitor and understand the report, it is important for us to note the context, you know, in the situation in our countries. So for Liberia, for instance, in terms of the context, and we'll be speaking in terms of service coverage and financial, in terms of the financial context, we have made strides on mobilizing domestic resources, even within the limited resource envelope that the government has, coupled with all of the many competing priorities. We have made remarkable progress in achieving or reaching the Abuja target. Currently, we stand at 14.6%, but we have substantial inefficiencies in the system, both geographical disparities and in terms of primary versus secondary care allocations. We also have some challenges, even though there is very high external funding as a share of the total health expenditure. We're still struggling with alignment, and contributions for the future are very uncertain. We are a post-conflict, post-Ebola country, so in terms of our health burden, the bulk of the burden is still with maternal health. We have one of the highest maternal mortality rates, coupled with neonatal and child health, even though we achieved MDG 4, but child health mortality is still high compared to other countries. So the burden we have of the disease is actually in the RMN-CAH area, and these are areas that we are prioritizing. And so what are the plans in order for us to address some of the issues I've just outlined? In terms of the resources, domestic resources issue, the inefficiency issues are being addressed with our partners like the World Bank. We're working on a formula for resource allocation, and we're also working on performance-based financing to kind of incentivize performance and add value to what we're doing. And then in terms of the long term, we're working on what we call the Liberian Health Equity Fund that will enable us to raise substantial finances for sustainable financing towards the UHC goals that we have. To address the RMN-CAH issues, the Global Financing Facility has been very instrumental in helping us to integrate the package and also focus on the priorities. So for now, we have the investment case that prioritizes interventions. The 6 of them are the emergency preparedness and response, surveillance, community engagement, leadership, governance and management, emergency obstetric and neonatal care services, adolescent health, and CVRS. These are the 6 packages we're focusing on, but based on the resource envelope that we have of the 15 counties, we're currently prioritizing 6 of those counties. Now, in terms of the epidemic or pandemic preparedness front, we recently established the National Public Health Institute of Liberia, which is an arm dedicated and mandated to take care of all of our epidemic issues, including research. And we currently completed a core capacity assessment for IHR, And plans are on the way to address all of the weaknesses that have been identified. Shortly before I end, in terms of the epidemic or pandemic preparedness, the key area of weakness or the key area of challenge for now is our ability to be able to detect and respond in terms of laboratory diagnosis, to get results from the laboratory diagnosis and be able to respond timely in accordance with the standards set for the WHO. So in short, these are some of the progress or some of the issues we're addressing as we make efforts towards monitoring UHC in our country. Thank you.
Thank you, Minister. So, Dr. Gaush Pasha, I'd like to ask you, what are the challenges of achieving the UHC agenda in developing countries in your view?
Thank you so much, and like my colleague here, I would also thank you for inviting me over here. And coming from Pakistan, which houses 207 million people of this world community, to my mind, I think the challenges that we in the developing world are facing are fourfold. I would broadly classify them. They are related to service delivery. They're related to health workforce. They're related to leadership and governance, and they're also related to healthcare financing. Now, these are important areas of challenges. When I speak about health service delivery, I'm talking about availability, and I'm also talking about accessibility. Equitable provision of health services is an issue. While provision in the urban areas is easier, rural areas is a real big challenge. So we have to confront them. When I'm talking about health labor force, the lack of it is also a very important challenge that we face on a day-to-day basis. To give you some numbers to demonstrate the problem, we have 1 doctor per 5,000 people in the province of Punjab. We have 1 nurse for 5,238 people in the province of Punjab. So health force, the right kind, the right skills are a major issue for us in the service delivery. Talking about quality of leadership and governance, quality of health provision is also a very, very important challenge that we face. The regulatory framework is an important issue that we have to face. The quality of drugs, the quality of service provision, again, are important challenges. And then finally, as far as the healthcare financing is concerned, while we have embarked on a path of reforms in which financing to health is increasing, at this point of time, we have something like $2 billion of financing going into healthcare. Over the last 3 years, it has increased by 200%. So I will take pride, it's 14% of our budget now. While we are increasing, and while we have a reform agenda in this direction, we, I feel, still have a very, very long way to go. And let me very quickly sum up for you some of the areas that we are processing at this stage as far as reforming the sector is concerned. Our focus to improve the quality is on primary and preventive healthcare. We realized our traditional approach of focusing on curative health is not the best way forward. Our focus has now changed to preventive. It's better to prevent than rather cure once you're ill. So that's a very big area of reform for us. In improving preventive healthcare, we are increasing the level of immunization. We are also increasing the level of our IMR. The infant mortality rate and the maternal mortality rate is lowering. Fortunately, unfortunately. We have seen a significant decline over the years. We are going for skilled birth attendance in particular, which was used to be an issue. At this point of time, we are hoping that 85% of the people would be having skilled birth attendants in the country, in the province of Punjab. Stunting, we feel, is a very important area, again, that we need to focus on. In our under 5 stunting rates are very high, and we need to bring them down very consciously. Then on improving the health quality, physically revamping the infrastructure is very important. And one thing that has been highlighted in the earlier session also, we need good databases. We need good IT interventions to monitor our coverage. This is an area which is of importance to us, and we are trying to bring in hospital management information systems as well to improve the level of quality of data and supervision there. As far as the health workforce is concerned, we have introduced flexible contracts and market-based salaries, but again, this constitutes a very, very major challenge for us. With countries where brain drain takes place, the best of our resources move out of the country, we need to somehow attract them back. And we need the help of our donor partners and the non-resident Pakistanis to come and help the country in filling up this gap. And we are trying to come up with innovative areas to attract them back. And then the government itself cannot take on this major task. Involvement of the private sector is very, very important. Both in terms of health insurance. We have launched a program of health insurance for the poorest of the poor. We have used very transparent and mechanisms, databases to identifying those people who are below poverty line or close to poverty line. And we are providing health coverage for them. We also are attracting the private sector in the management of health sector provisions and in some of the clinical and non-clinical services related to the health sector. So I think the challenges are there. They are major. We have put in a strategy that will take us in the right direction. We need innovative approaches. We need strategic directions. We need strategic partnerships to take us out of where we are. We need good partnership. I see a lot of common issues from the people sitting around the table. Our issues are common with you. Many of you, we're here to learn from you. We're here also to share some of our experiences, and let's find a way out of this. We stand committed to the SDGs, and we are taking our steps forward in that direction. Thank you.
Thank you. Very interesting. So, Rosemary, what is the civil society perspective on the current status of monitoring, as in fact outlined by the Global Monitoring Report?
Yeah, thank you so much. So I'll respond to that question from 3 dimensions. So first of all, looking at who is being covered, by what services, and how is it being financed. So in terms of who is being covered, the report shows that we still have about half of the world's population still lacking access to essential health services. Within that, we have seen that we have more than 200 million women still lacking adequate access to family planning services, more than 20 million children still lacking access or unable to receive 3 essential immunizations. And so within that, we also see high levels of inequalities. And so with that, I think the highlight for us as civil society here is to say that all these exclusions are not just because of challenges within the health systems, as outlined earlier by the minister, but also because of income, actually heavily because of income, because of education, because of social barriers, because of discrimination. If we are going to advance the concept of leaving no one behind, these things need to be addressed: discrimination, social barriers, etc., etc. And we really need to uphold the concept of leaving no one behind. If you look at the next level, which is what services are being covered, we have evidence through current data showing that there is a tendency by countries to focus and invest in tertiary services at the expense of primary services. So the key highlight for us here is that there will be no universal health coverage without primary health care. And the other thing we have seen is that services and systems and facilities tend to be provider-oriented or provider-centered. And we're also saying that there will be no universal health coverage unless the programs are people-centered and are anchored within the principles of human rights. When you come to the third element, which is how our services are being financed, unfortunately, as we have seen the data, it is being financed through rising user fees, rising catastrophic healthcare expenditure, and low public health investment. So it's quite exploitative for communities and for people in general, where people are being forced to choose between staying healthy and staying out of poverty. And the biggest highlight is that has to change, and we have to look at how we address that. So as civil society, we are calling for and really pushing towards having universal health systems being predominantly financed through public funding, with a focus on primary health care and a focus on community systems. So we are calling for governments to invest at least 5% of their GDP into health, with a focus on primary health care and community systems. You'll see a lot of us wearing these badges. And we'll also, as inspired by Stephanie, we might actually come up with a 5% song. So watch that for that. But we're also saying that calling for domestic resource mobilization and investment does not mean that there is no place for international global solidarity and aid. What we are saying is that there is a place for both, and current financial commitment by donors needs to be met. For example, the 0.7 GNI need to be respected, and also commitment to increase development assistance, including through multilateral financing institutions like the Global Fund, like the Global Financing Facility, like Gavi. All those will come into support, and everybody has a place to play in terms of meeting universal health coverage. So, in conclusion, every player actually needs to look at promoting equity, ensuring no one is left behind, ensuring programs are people-centered, and are anchored within human rights principles. Thank you.
Thank you very much. You have a fan club here. So, Gonel, what in your view are the implications of this, the Global Monitoring Report findings for the work of WHO related to health security, which is as important as the rest?
Thank you very much, and good morning, everyone. In fact, I'm very pleased to be here because I'm not from the UHC community. Traditionally, I'm more from the health security community. And I'm very pleased to have this opportunity to link the two through this session on improving health security. Because when you look at it closely, you're looking at the two sides of the very same coin when it comes to health security versus UHC, universal health coverage. It's very easy to understand that universal health coverage cannot be really achieved when healthcare workers are actually busy fighting an health emergencies, or even being the first victim of an outbreak. We saw that during SARS, especially in these regions, but also through pandemic influenza, through Ebola. It's very clear that in the middle of a health crisis, universal access to healthcare can simply not be achieved. And we're facing in West Africa some problem, for instance, with immunization campaign that could not be done at that time, and pregnant women that could not deliver babies at that time in the proper conditions. So these two sides of the same coins need to be addressed. And they can be addressed by and first of all, understanding the mutual reinforcement of both efforts. When you invest in universal health coverage, you actually contribute to health security. And when you invest in health security, you contribute to UHC. But this investment should start certainly with the most fragile and conflict affected countries. It was very much highlighted this morning by the representative of the World Food Programme that we're dealing with universal health coverage, but we're also dealing with this enormous problem of health security that is a major obstacle. So we need to invest to prevent, detect, and respond to health crises, outbreaks, etc. And that's actually, over the last few years, there is a momentum, especially on post-Ebola, but about the implementation of the international health regulations. And the international health regulations have recommendations about capacity at national level, but it's more than recommendation. In fact, there are legally binding requirements that countries have to have certain capacities, capacity to detect, to respond or to prevent a crisis. And it's very interesting because when you look at the international health regulation core capacity requirement, they actually cover many of the essential health functions which are required for achieving UHC. So there is a strong rationale to work together. And I would say through this momentum, which has been highlighted by the G7, by the G20, the World Bank, also there is, I would say, a global sense that we should avoid health emergencies because they affect UHC, they affect the economies. But also, I think we need to develop the concept of resilient health system, resilient UHC, and not just to have UHC in a wonderful peacetime when in fact many countries and the most fragile ones are actually affected by crisis. We do need to monitor these capacities, being capacity under the international health regulations, but also capacities to achieve UHC, the essential public health function, for instance. So WHO has actually developed a full program, the WHO Health Emergency Program, focus on helping countries to be better prepared for emergencies. And I will stop here, but for instance, the joint external evaluations allowed countries to not only do their own evaluations, but also to have an external view from peers to see how they are prepared, and we can have similar concept for UHC, not only to rely sometimes on self-assessment. Thank you very much. I'll stop here.
Thank you. So, Mukesh, what is the bank and WHO making together to support countries to monitor health security globally and at country level? Can you tell us what you are doing?
Thank you. We see health security as a fundamental element of UHC. This is a point that Gunel has made, a point that was made earlier as well. So just the same way as we have measures for different aspects of UHC, and we saw earlier on in the presentation measures on coverage, measures on financial protection, we also need to have a measure on health security. And that is fundamental if you want to speak about effective UHC. For that, together with WHO, the World Bank is, as we speak, exploring options of establishing a global monitoring board. This notion of the global monitoring board was mooted way back, actually, at the time of the Global Health Crisis Task Force, which was convened by the UNSG and which was co-led by the Deputy UNSG, by the WHO DG, and the World Bank President. We believe that for such a global pandemic monitoring board, for this board to be effective, it has to have the technical capacities, it has to be seen as being credible, it has to be independent, otherwise it will not be recognized, and it has to have the clout, because people would then have to respect it and honor it, and countries have to see that report and to accept it. This is a complicated task, obviously, because it involves not only monitoring aspects within the health sector, but also outside of the health sector, in agriculture, in veterinary, in disaster risk management, in finance, in trade, and so on. And as Minister Pasha noted earlier, the role of the private sector is also extremely important in pandemic preparedness and response. And that also is something that has to be monitored and accounted for and measured in some way. At the end of the day, we see this process as leading to the development of an index. Just the same way as we in the world have strengthened our financial security system, and we have developed these indexes which are used by the finance ministries and by others to both monitor and to assess and to value the inflows of FDIs and loans and so on. We should have a measure also of health security, which has to be put at the same level as financial security. As we have seen in the last 2 decades, the huge impact of major outbreaks on the country's economy. Next year, we mark the 100 years of the Spanish flu. And I think it is extremely important as we think about that is to strengthen a measure and to have a system by which we can then continue talking about health security in a meaningful manner. Several such indexes have already been developed, those by Metabiota, those by the RAND Corporation, one that is being developed by the Nuclear Threat Group. So we have to bring all of these things together, find a way in which there is broad consensus across the world, something that countries accept, and something that countries and the world then starts responding to. We were having a conversation earlier this morning with Minister Pasha, and she said that for the ministries of finance, what is extremely important is to understand the importance of what is happening in the health sector and the extent to which that affects finance and economy. And the only way that this will come up is if we have something that can be measured, something that we can then say that if this number is low, then the country is not only at a health risk, but also at financial risk and at an economic risk. We have to raise the level and raise the importance of health security, because if we don't do that, we shall continue to be vulnerable and we will not be able to achieve UHC targets by 2030. Thank you.
Thank you. So please join me with a big applause to our panelists. And now I want to open the floor for questions to the panel. Yes, please. Yes, can we? Yes. Can you please identify yourself?
Very good. My name's Nigel Crisp. I'm a member of the House of Lords in the UK. I was very struck by the data that you are collecting, including complicated data on health impoverishment and so on. But I didn't hear much about data about human resources. And have we got enough data about human resources? Do we know what's going on in terms of how the service is being delivered? People talked about primary health care, and do we have enough data? And are we monitoring what's happening in that area? Thank you.
Thank you. Let me collect a couple of additional questions before turning to the panel. Yes, Rosita, please.
Thank you. It struck me very interestingly when I heard the whole morning session where we talk about health for all, and even in our logo, we seem to be missing a very recalcitrant group, which is the men's health issues, the younger men. I mean, we have the elderly there. And so I wanted to bring that up, even in the context of conflict countries. And also, well, in the context of middle-income countries like Malaysia, we see that our adult morbidity and mortality with NCDs, etc., with the men, it's actually improving far less than the women, because the women get early exposure through MCH and the children are grown up. So I'm worried that we're missing a group of recalcitrant people who need to be addressed, especially with NCDs in conflict countries. Thank you.
Thank you. Yes, please. If you can stand up and identify yourself, please.
My name is Ben Akabueze, Nigeria. The goal of spending 5% of the GDP on health sounds great. But for us, the entire budget is 11% of GDP. So, clearly, it's not feasible to spend half of the entire budget. And I'm talking about the budgets, combined budgets of the federal and subnational governments. Therefore, what suggestion would you have for countries like ours that face such dilemma? Because the one way to grow the public expenditure is by increasing taxation, which takes in from the people. Some people argue that you're better off than leaving them with a higher out-of-pocket expenses than trying to take the money as tax to provide the service in a less efficient way. Just, some ideas about how we can.
Thank you. So I think I'm gonna ask John to perhaps respond the data questions. Given that you manage the information, evidence, and the question was, how are you going to monitor, for example, men's-related thing and then things that appear to be sort of absent?
Thank you. On the question of the different age groups, again, as I said earlier, the index exposes a number of these kinds of gaps in the data. And so I think that we have a few different options. One is we have some surveys that are actually ongoing, focusing on older populations. I think the other thing is to try to look at those data sets and try to standardize the amount of information we need on those age groups and work with countries to make sure that some of those standards are being put into place that will serve those needs. But I would say that it is a gap, and it is something that was revealed in the process of putting together the index, and we're in various discussions on how to expand the age ranges appropriately without overwhelming countries with brand new surveys and different efforts. So I think it's something we're certainly paying attention to.
Thank you. So Rosemary, would you like to respond to the question on the 5%?
Yeah, so I'll defer it to my colleague, Simon Wright, who is right here in the audience. Yeah.
Thank you. I think from civil society, we recognize it as a national government decision about how much to tax people and how much of that to allocate to health. But all of the evidence is very clear. Collecting public funding and spending it on health is the fairest and most efficient way. Leaving it to out-of-pocket payments is unfair, condemns the poor to poverty and to not accessing healthcare. And 5% of GDP in all the literature suggests as government expenditure is pretty much about the right minimum for a government to spend, not to leave to people to spend out of pocket, but government expenditure. So that's why we're wearing the 5% badge.
Thank you. Minister Pasha, would you like to also respond to that question?
Actually, the question that has been asked is a question that we finance ministers are bogged down with every fiscal year. How much money to allocate to health sector? And it's actually not an easy decision to make because our pockets are limited. There are trade-offs. If you're putting in one sector, you're taking it away from the other sector. Now, what is very important for us to realize is that universal health coverage has a very close link to poverty and growth. And I think for our decision making and our putting in more money towards health is influenced by this realization. It's not just about curing people, it's also about making a better quality of, giving a better quality of life to the people, bringing them out of poverty, because a very large segment of the population goes into poverty because of emergent health expendings. This is a demonstrated fact. A lot of us become poor simply because there has been a catastrophic health incident in the family. So preventive health is something that we need to give more focus on. This is our mechanism of ensuring higher growth. The link between the two has been demonstrated in the morning session also. And I think we as finance ministers should always remember this, that this is just not about social sector, This is about overall economy. This is about overall poverty reduction. It's not only just health. And that will help us in some ways, mobilizing and leveraging the private sector, seeking help through development partners like we have around here are other mechanisms in which we can do it. But 5% or not 5%, the spendings need to be increased, and we need to do it urgently and with a lot of motivation. I think political will is what is needed, and we will gear for it. You, along with all of us, we should push for it. This is needed, and that's the way forward.
Great. Thank you very much. On that note, I'm sorry we are just running out of time. I just want to conclude by re-emphasizing some of the key messages. The first one is that even though we had been progressing toward UHC, we still have a long way to go. With the data that were presented, and in particular related to equitable access to care. We need to accelerate progress on all fronts, effective service coverage, financial protection, and also health security if we want to achieve SDGs by 2030. And regular UHC monitoring appears to be critical to ensure timely feedback on progress and promote cross-country learning. And I just want to emphasize the need for data that we have from all countries, and in particular data that we currently do not have available, like NCD-related and other data, and the need to implement vital registrations as the way to collect data instead of relying on health surveys that are sample data. So with that, I want to thank again the panelists and the presenters, and to you for being with us today. Thank you.
Thank you very much for a very insightful panel. Before we move to the coffee break, I just wanted to explain how the next couple of sessions will work. We have an exciting selection of breakout sessions, which will take place on the 3rd and the 11th floors of this hotel. The exact locations are in your program book. The first one will start promptly at 11:30. And the second one will start at 2. So seating is limited and on a first-come, first-served basis. In between, we have lunch in the Garden Islands Beer Restaurant, which is right outside the hotel to the right. Go out the main entrance and go to the right. Next plenary session will be here at 3:30, so please make sure that you're back in this room by 3:30. Enjoy. Oh, thank you.